Hi, I'm Dr. Scott Triedman. I'm a radiation oncologist, and I work with the Dana-Farber Center for Global Cancer Medicine and Partners in Health. Today I'm going to be talking about the basics of cancer therapy and specifically about radiation therapy and trying to give you an overview of what's involved in treatment and some things you need to know. Most of the slides that we're going to be looking at today were adapted from the American Society of Therapeutic Radiation Oncology talk, Radiotherapy for Health Professionals, and I added on some additional cases to try to highlight what we're talking about. Before we jump into this talk on radiation therapy, I think it's important to remind all of you that we need to be thinking about radiation therapy as one piece of a much wider cancer care continuum. This continuum includes everything from prevention and education through screening and early detection, all sorts of diagnostics, systemic therapy, surgery, palliative and survivorship care, social support, including transport and food. So all of these things need to be taken into consideration, and radiation therapy can't be thought of as one treatment in isolation. Cancer care requires all of these components to be successful. So the objectives of the radiotherapy talk today include the following. Number one, I'm hoping that you come away with at least a basic understanding of the physical and biologic basis for radiotherapy. I hope you also understand some of the clinical applications of this important cancer therapeutic. I think it's also important that you have some understanding of what the side effects are of radiation therapy, both early side effects that occur days to months into radiotherapy and shortly after, and also the late side effects, which can occur months or years after radiation therapy, as you're going to be seeing some of these patients in your clinics and hospitals. In addition, I'm hoping that you can have a basic understanding of what the radiotherapy treatment process looks like, and also understand the couple of different types of radiotherapy that are most commonly available and used in practice. Just as means of introduction, radiation has been an effective tool for treating many different cancers for over a century now. Over 50% of patients who are diagnosed with cancer are candidates for RT as part of their cancer treatment, either as a curative therapy or as a palliative therapy. Radiation oncologists are the specialists who manage the care of cancer patients for either cure or palliation. In addition, radiation therapy is using what we call high-energy ionizing X-rays to destroy a cancer's ability to grow and multiply. When we talk about dose with radiation, we use the unit of gray, and 1 gray is equal to 1 joule of absorbed energy per kilogram of tissue. The goal of radiotherapy is to deliver a precisely measured dose of irradiation to a defined tumor volume, while at the same time trying to minimize any damage to surrounding healthy tissue. I think this is probably the most important sentence that you're going to be hearing today. The goal of treatment is to try to get the dose where you want and to minimize the dose to the surrounding healthy tissue, thereby minimizing damage to this tissue. Successful radiation treatments hopefully will result in tumor eradication, local tumor control, improved survival, symptom palliation, and at the same time cause minimal side effects. So with external beam radiation therapy, you're typically using what we call a linear accelerator. That's external beam radiotherapy. The other type of radiotherapy that's commonly used is brachytherapy. Now, brachytherapy is different than external beam radiation. It's internal radiation, and it delivers radiation by placing a radioactive source into or just adjacent to a tumor. And we'll talk more about that later. When we talk about radiation therapy, as I said, external beam radiotherapy with the linear accelerator on the left. internal radiotherapy or brachytherapy through what we call a high dose rate brachytherapy afterloader that you can see on the right. The sources of radiation are what we call photons, and we're talking about either X-rays or gamma rays. X-rays are the type of ray generated by a linear accelerator where electrons are accelerated, they hit a target, and they produce photons or X-rays. Gamma rays are emitted from the nucleus of a radioactive material, and that's what we use in brachytherapy or cobalt treatment with an external unit, which again is what we call a hot source where gamma rays are being used. The effect on the tissue that are seeing these rays are the same regardless of whether it's X-rays or gamma rays, although there are certainly differences in terms of dose delivered depending on how this is applicated. Looking at the biologic basis for radiation treatment, it's important to understand that radiation therapy works by damaging the DNA of cells and destroying their ability to reproduce. It's also important to understand that all tissues have a tolerance level or a maximum dose beyond which irreparable damage may occur. That goes for both cancerous tissue and normal tissues. Both normal and cancer cells can be affected by radiation, but cancer cells generally have an impaired ability to repair this damage, and that can lead to cell death. As I said, when we treat with radiation, both normal and cancerous tissue or a tumor is being treated by that radiation, but the tumor cells are generally more sensitive than the normal tissue. So at the same dose, more cancerous tissues will die than normal tissues. And radiation treatment tries to exploit that difference. Another important concept to understand when we talk about radiotherapy is fractionation. This is a rather basic radiobiologic principle. And what we're talking about when we talk about fractionation is that dividing the total dose that you deliver with radiation into multiple small daily fractions, usually over weeks, can take advantage of differential repairabilities of normal and malignant tissues, enhancing your ability to kill the cancer cells while sparing normal cells because they have generally better repair mechanisms available than malignant tissue. So fractionation typically produces better tumor control for a given level of normal tissue toxicity than giving one big single large dose. There are situations where we may want to give very large doses. Obviously, we're always trying to minimize the number of trips a patient has to make to get radiotherapy. But again, for different situations, you're going to be using different fractionation regimens in different clinical scenarios. So when we treat someone with radiation, we first need to target or plan the therapy, and you can see that on the left. Then we deliver the radiation. In this case, it's with an external beam treatment machine or a linear accelerator. Subsequently, that treatment has an effect at the cellular level, and you're damaging DNA with this treatment, leading to cell death. And what's happening is the cancer cells, which are usually rapidly proliferating, die as a result of that radiation treatment, while the normal cells, as I just said, which are generally more slowly dividing, can often repair that damage effectively. So therapeutic radiation serves two major functions. Number one, in some cases, it can cure a cancer, and it generally can cure a cancer if adequate dose can be delivered and it's a localized tumor. When we talk about curative treatment, we're also talking about radical treatment, treatment that's destroying a localized tumor that hasn't spread. It also may be used as what we call an adjuvant, where it kills microscopic disease before or after definitive surgery or chemotherapy is used. So it's important to understand that curative treatment with radiotherapy could be radiation alone in some cases. It could be radiation and chemotherapy in other cases. It could be radiation and surgery and chemotherapy in other cases. It all depends on the clinical situation. The other very important use of radiotherapy is to try to palliate cancer symptoms, try to help patients deal with symptoms related to their disease. And the way it does this is by shrinking tumors that are affecting quality of life. Examples would be a big tumor in the chest that may be compressing a bronchus, causing shortness of breath. It can also palliate cancer symptoms by alleviating pain, such as in a bone, or it could palliate symptoms by removing compression against the spinal cord by shrinking the size of the tumor. The delivery of external beam radiation treatments is painless. It usually takes a few minutes each treatment when you're talking about external beam. And it's usually scheduled for 5 days a week. As I said, depending on your fractionation schedule, it can be really anywhere between 1 week long and 8 weeks long in some situation. It's also important to remember that side effects of radiotherapy are cumulative, with the most significant side effects occurring near the end of treatment. When we talk about curative radiotherapy, it's important to know that radiotherapy plays a major role in the management of many common cancers. As I said, this can either be alone or it can be as an adjuvant therapy in addition to surgery and chemotherapy. Some of the commonly treated cancers treated with radiotherapy, either as primary therapy or as adjuvant radiotherapy, include things like breast cancer. So in an early breast cancer, you might do a lumpectomy or a wide excision, follow it with radiation treatment, and in some cases, you may also include hormonal treatment and chemotherapy. It all depends on the specific clinical situation. Gynecologic cancers are frequently treated with radiation as a curative modality, and as a for instance, things like cervical cancer, and we'll talk more about that later when I present a case. In addition, prostate cancer is often treated with radiotherapy as an alternative to surgery, or sometimes after surgery when there are high risk factors requiring adjuvant radiotherapy to reduce the risk of it coming back. Other diseases include things like lung cancers, pancreatic cancers, esophagus, multiple different head and neck cancers, brain, skin, lymphomas, bladder, sarcomas, colorectal cancers, and bladder cancers. So again, there are lots of different cancers that are treated with radiotherapy, either as primary therapy or adjuvant therapy. So I thought I would just present a case to illustrate what I'm talking about when I'm talking about curative treatment. In this case, it's a head and neck cancer case. In this case, a patient presents. He's 60 years old. He's a smoker with a history of hypertension and COPD, although in reasonable shape. And he presented with a non-resolving left-sided sore throat, some mild dysphagia, anorexia, and a 12-pound weight loss. He also noted a painless left mid-upper neck lump. Of note, this patient has no history of alcohol abuse. His laboratory studies were normal. His HIV test was negative. On exam, this was a somewhat cachectic male due to his anorexia and weight loss. He had a just over 4 centimeter left base of tongue lesion, which was visible and palpable. In addition, he had lymph nodes that were palpable and not fixed, measuring 3.5 centimeters on the left and 1.5 centimeters on the same side. There were both mid and upper cervical locations for these tumors identified. The remainder of the exam was unremarkable. Imaging was obtained, and the CT scan demonstrated this large left base of tongue lesion. There were bilateral neck lymph nodes CT of the chest and abdomen were unremarkable with no evidence of metastatic disease. And in this setting, there was no MRI or PET scan available. A fine needle aspiration biopsy of the left neck lymph node was consistent with a poorly differentiated squamous cell carcinoma. It was HPV negative. So the patient underwent an ENT evaluation, which was consistent with a clinical stage T3. That's a fairly extensive, large tumor, as we saw. N2C nodal stage due to the multiple lymph nodes that were with bilateral involvement, and M0, no metastatic disease evident. So it was a stage 3 base of tongue cancer, which is a type of oropharynx cancer. As I said, HPV was negative. The assessment was that this patient had a local regionally advanced squamous cell cancer of the base of tongue. The plan at that time was to refer for multidisciplinary evaluation, including ENT, radiation oncology, and medical oncology. In addition, it was felt that the patient needed some symptom management, so those were addressed. The patient also had nutritional and dental evaluation and support, both given his weight loss, but also in anticipation that he may lose additional weight and have further nutritional compromise during his course of treatment. And the patient was counseled in smoking cessation, very important here. The team then looked at the NCCN harmonized guidelines, and in this case, surgery was not favored. The multidisciplinary team favored primary curative radiotherapy in conjunction with platinum-based chemotherapy, and then reevaluation for response both in the primary site and in the neck. So we just talked about curative radiotherapy. What about palliative radiotherapy? As I said, palliative radiotherapy plays a very important role, and I might suggest that it may even play an outsized role in a setting like Rwanda. In this case, in your country, we know that the majority of patients are presenting with advanced disease, which is in contrast to some of the higher resource countries. So at least 50% of patients may benefit from radiotherapy at some point in the course of their disease. And about half of those patients who have bone metastasis may have significant or even total relief from their pain. It may not be sustained indefinitely, but there's a good chance they're going to have some pain relief, and maybe for a number of months, which for somebody who may be at end of life may provide real significant improvement. So about 80 to 90% of all patients with bone metastasis present with some relief following palliative radiotherapy. Other palliative uses of radiotherapy include things like spinal cord compression, vascular compression, including things like SVC syndrome, which you'll hear about in another talk, bronchial obstruction, as I mentioned before, or bleeding from GI or gynecologic tumors, things like that. So I thought I might present just an illustrative palliative bone metastasis case. In this situation, we have a 62-year-old male with a 3-year history of metastatic adenocarcinoma of the prostate. At initial presentation, this patient had bone and lymph node metastasis, 2 very common sites for prostate metastatic disease. At this point, a few years into his disease, the patient has developed severe and debilitating low back pain. He has no neurologic or bowel or bladder symptoms. His performance status isn't perfect at this point. It's an ECOG of 2, probably mostly attributable to his severe pain. In terms of prior therapy, he had a bilateral orchiectomy initially with an initial excellent response a few years ago, which continued for a few years until the current presentation with back pain. Initially, his PSA dropped. He had a good clinical response. The patient also has had no prior radiotherapy. This is very important because whenever you're considering treating somebody with radiotherapy, you really want to know if they've had any prior radiotherapy, which may preclude treatment. In general terms, we don't tend to retreat areas that have already been treated to full dose, although there may be a few exceptions to that particular situation. For this patient, he now is showing evidence of a rapidly rising PSA, as I said, progressive bone pain, and anemia. He has normal liver function tests and calcium. In terms of his radiographic workup, his plain x-rays demonstrate diffuse blastic metastatic disease in the lumbosacral spine. His MRI demonstrates diffuse bone metastasis, most notably from L3 to S1. There's no spinal cord or cauda equina compression seen, and the assessment made by his doctors is that this unfortunate gentleman has progressive hormone refractory metastatic prostate cancer with symptomatic lumbosacral spine bone metastasis. So the plan in this case was for a semi-urgent RT consult for lumbosacral radiotherapy. I said semi-urgent because he does not have a spinal cord compression. He's just in a lot of pain. So we want to try to move quickly so we can try to palliate those pain symptoms. We also want him to be evaluated for improved pain control with medications. And we want the oncologist to evaluate the patient for possible second-line hormonal or systemic therapy to address his disease throughout his body. Remember, the radiotherapy in this palliative setting is to that area that we would be treating, the lower lumbar and sacral spine, not the whole body, although he clearly has progression at multiple sites. So now that we've talked a little bit about curative and palliative radiotherapy, I wanted to take a few minutes to talk about some of the side effects of radiotherapy. I think this is important, number one, because you're going to be seeing some of these patients in your hospitals and clinics. Seeing the side effects can be scary at times because they can be pretty dramatic. In most cases, early side effects resolve, but patients may need some support while that's going on. So when we're talking about complications of radiotherapy, these side effects depend on a number of factors, including the site of radiotherapy treatment and what adjacent organs were at risk, what adjacent organs saw significant doses of radiation. Another factor is the type of radiotherapy delivered. Is it external beam? Is it internal radiotherapy or brachytherapy? What's the energy of radiotherapy that's delivered, because that can determine how penetrating that treatment is. And what was the total dose and the fraction size? How was it delivered? Was it delivered in a few very large fractions, which may cause more side effects in some situation? Or was it smaller fractions, fraction sizes over a longer period of time? Also, a very important thing is what types of patient comorbidities does the patient have? Is the patient a heavy smoker? That may increase certain side effects. In some patients who have HIV, when you're treating them, they may have more acute reactions. If patients are receiving chemotherapy, they may have more side effects. And also, as I said, has the patient had any prior radiotherapy? So when we talk about side effects, early side effects occur during the radiotherapy course and a couple of months after completion, and these are usually reversible. Late side effects usually start greater than 3 months after the commencement of radiotherapy and may occur even years following radiotherapy. The important thing to remember about late effects is that while early effects are usually reversible, late effects may be permanent. So when we talk about acute side effects, what are some of the side effects? Many patients who receive radiotherapy have fatigue. When you're treating skin, you often see redness or erythema, hyperpigmentation, hair loss. There can be bone marrow suppression, particularly when you're treating large volumes of pelvis or spine. When you're treating the head and neck, there can be a lot of mucositis or dysphagia, taste changes, weight loss. When we're treating a chest, there can also be esophagitis, there can be inflammation of the lung, there can be dry cough. When we're treating abdomen, you may see things like nausea, vomiting, diarrhea. In the pelvis, things like rectal bleeding, hematuria, and vaginal irritation. So again, it's very dependent on where you're treating and the dose that you're treating and how much normal tissue is in the area that you're treating. When we talk about late side effects, as I said, these tend to be less common, but of greater concern and may be permanent. When we're treating brain tumors to high dose, we worry about things like necrosis of normal brain tissue, things like blindness and cognitive dysfunction. When we are treating connective tissue, we can see lots of fibrosis and scarring and sometimes ulceration. When we're treating lung in the field, we can see pulmonary fibrosis that can lead to chronic shortness of breath. GI tract, it can lead to things like chronic diarrhea, bladder bleeding or fistulas. It can lead to infertility, and nerves can lead to things like paralysis. In addition, one thing that we can see is second cancers being induced by radiation. I don't want to overplay the likelihood of developing really serious late effects. They can occur, but we always weigh that into the equation. We know that to cure a patient, we may have to accept a certain, hopefully small level of serious radiation damage, when we know if we don't give an appropriate dose to cure a cancer, it will not adequately treat the cancer and lead to a recurrence, which as radiation oncologists we often see as the worst side effect of treatment, it being inadequate treatment leading to a recurrence. So switching gears, I want to talk a little bit about the radiation therapy planning and treatment process. This is schematic, I think kind of outlines the four broad steps that we're talking about. The initial consultation by the radiation oncologist, followed by simulation. After that, all of that information is brought to the physics team, and they do all the planning in conjunction with the radiation oncologist. And then once all of that information has been thought about and a treatment plan has been constructed, the patient is actually treated with the plan that's been developed. When we talk about sending a patient to radiation oncology, patients are being sent to the doctor, the radiation oncologist, but it's important to understand that there's a whole radiation oncology team, including a physicist that ensures that treatment plans are properly tailored for each patient, and the physicist is also responsible for quality assurance and calibration on the machine. We have dosimetrists, which help develop the treatment plan and calculate the proper dose of radiation to be delivered each day. We have what we call the radiation therapist. Those are the technologists who actually are the ones on the machines administering the daily radiation under the doctor's prescription and supervision. And then we have radiation oncologists who support and follow the patient throughout the treatment process and beyond. So patients are referred to the radiation oncologist usually after a tissue diagnosis of cancer has been established, and usually after a staging workup has been complete to make sure that we know whether the patient has localized disease or metastatic disease, as that will inform your treatment recommendation. The oncology team then reviews the treatment options with the patient at that point. So the radiation oncologist will determine whether radiotherapy is appropriate for that patient or whether a different form of therapy should be considered, like surgery or maybe chemotherapy. At that point, the radiation oncologist will develop an overall treatment plan. The care is coordinated with other members of the patient's oncology team at that point. At that point, the patient will be brought for the planning or radiotherapy simulation. At that time, the patient is set up in treatment position on a dedicated CT scanner. You may use different immobilization devices, and we do that to assure that the patient is treated in an absolutely reproducible fashion each day in a comfortable fashion, but in a way that you can have millimeter or even in some situations sub-millimeter accuracy. Patients are then scanned in the treatment position in the exact same position that they'll be treated in every day with their external beam treatment. And then patients are usually marked or tattooed so they can help set the patient up in an exactly reproducible way every treatment. So after the CT simulation, all of the information from that scan is sent to the physics and planning team. They review the data and imaging obtained during simulation. And then the radiation oncologist outlines the target volume with the margins around that tumor. And also they outline the organs at risk. So if you're treating a prostate, they'll also outline organs like the bladder, the rectum, the femurs, things like that, that will also see radiotherapy during the treatment course and need to be considered as those organs are at risk for toxicity down the road. When treatment planning is done, the planners use very sophisticated software, and what they're trying to do is help design the best possible treatment plan. They're trying to push the radiation where they want and minimize the radiation to where they don't want. After they develop a plan, each radiation treatment plan goes through rigorous checks and quality assurance. The radiation oncologist reviews and finally approves the final plan. So now the patient is ready for treatment. So just to summarize the goal of that treatment planning process, the radiation oncologist and physics team work together to develop a treatment plan which attempts to target radiation to cancer cells while keeping the dose to normal cells as low as possible. So I'm going to talk about the three common types of external beam radiotherapy next. There's 2D radiation, 3D radiation, and IMRT. With 2D radiation, this is generally an older technique where treatments would be planned by defining a very limited number of beams with the boundaries delineated on x-rays of the patient. Here you see a tumor in the lung area, so you would basically define the area you want to treat, which may be the tumor and some adjacent nodal areas. You would come up with a fairly simple plan and proceed. 2D radiotherapy has largely been replaced by other highly conformal external beam therapies, which are used to plan the treatment. Now, 3D conformal radiotherapy uses cross-sectional imaging, CT or MRI, to create a three-dimensional picture of the tumor and surrounding anatomy. Radiotherapy planning software is then used to design what's a much more complicated beam arrangement, and they can assess dose and volume for the tumor and those organs at risk. 3D conformal radiotherapy is a big jump from 2D conformal therapy, where you're able to treat with improved precision and decreased normal tissue damage. The most modern type of delivering radiotherapy is with something called intensity modulated radiotherapy, or IMRT. IMRT is a very advanced form of 3D conformal radiotherapy, and it allows your radiation beams to be shaped even more precisely to fit the tumor. I think of it as trying to shrink wrap your high dose region around the tumor with rapid fall off. So the high dose region is given to the tumor, and the dose delivered to the adjacent structures is much less. So this allows you to give a higher dose to the tumor and also to spare more normal tissue. So that was external beam radiotherapy. The internal radiotherapy that I mentioned at the beginning of the talk is called brachytherapy. With brachytherapy, radioactive sources are implanted directly into the tumor or surrounding tissue. Multiple different isotopes are used. The purpose, again, is to deliver high doses of radiation to the desired target while minimizing the dose to the surrounding tissue. And brachytherapy is often used in conjunction with a course of external beam rather than just as a sole modality. So you may get a course of chemoradiotherapy and then follow it with some internal radiotherapy to give an additional high-dose boost to the area at greatest risk. Brachytherapy, as I said, is delivered directly into a tumor. This is a schematic looking at the delivery of high-dose rate brachytherapy with applicators in the cervix in this sagittal view. The middle picture is of what we call the afterloader, where the sources lie, and then they push up and go down those yellow catheters into the patient. And the X-ray on the right is just a confirmation film that your applicators are in position for this particular cervical cancer treatment. So there are two types of implants. There's permanent implants, and those are implants that release small amounts of radiation over a period of several months. Those are placed and then left there indefinitely. And then there are temporary implants, which are used more frequently these days, and those are left in the body usually for a few minutes, and in some cases for a few days, and then removed when desired radiation dose is delivered. A type of temporary implant is high-dose rate brachytherapy, which is what that afterloader machine that we just saw does, and that refers to a type of frequently used temporary implant where you're delivering a very high dose of radiotherapy, usually over a few minutes. So I thought I would wrap things up with a cervical cancer case. In this situation, we have a 38-year-old healthy G2P2 female with new onset vaginal bleeding. Labs were within normal limits. The patient is HIV negative. Pelvic exam revealed a large friable cervical mass. The remainder of the exam was normal. A cervix biopsy was done and was consistent with a poorly differentiated squamous cell carcinoma. On exam, under anesthesia, this patient was found to have a 5-centimeter cervical mass with upper vaginal extension that involved the right parametrium, but not the pelvic sidewall. Cystoscopy and proctoscopy were done, and they were negative for local invasion. Imaging included a chest x-ray, which was negative, a CAT scan of the abdomen and pelvis, which revealed a 5-centimeter cervical mass, no lymph nodes or distant metastases identified, and no hydronephrosis. On this image, we have a CT slice showing a cervix cancer extending posteriorly and consistent with full-thickness stromal invasion, similar to what we're talking about with this patient. So the assessment here was that the patient had clinical stage 2B disease. That's by FIGO, which is the staging system that we use for gynecologic cancers. The biopsy confirmed a poorly differentiated squamous cell carcinoma of the cervix. The plan at that time was to get multidisciplinary input from GYN oncology, radiation oncology, and medical oncology with consultations. The outcome of this multidisciplinary clinic evaluation was that this patient had somewhat advanced and bulky disease, so was not an ideal surgical candidate for radical hysterectomy due to the disease extent. So the radiation oncologist and the GYN oncologist agreed that the patient is a good candidate for curative chemotherapy and radiotherapy. So the treatment followed, again, the NCCN harmonized guidelines for sub-Saharan Africa and went ahead with curative chemoradiation with external beam radiotherapy to the pelvis and brachytherapy with concurrent cisplatin chemotherapy. So just to close up here, when we talk about radiotherapy, it's always important to remember that follow-up care is very important. Oncologic follow-up cancer is mandatory on all these patients, and you want to assess treatment outcome. Was the patient cured, or did the patient have a recurrence? Because you need to know both of those things. And in addition, as I said, you need to evaluate for late toxicity and address that, because if the patient has serious late toxicity, that can be a real significant burden that can impact the patient's quality of life. Just to conclude, I wanted to show a picture of the department at RMH that went online about 4 years ago. They have 2 linear accelerators, really top machines. They have a CT simulator. They're able to give concurrent chemotherapy. Brachytherapy is planned, although not available yet. Things got delayed a bit, I think, because of the pandemic, but hopefully that's on track. So I'll close there, and I'm happy to answer any questions, and thank you for your attention.